Canine impaction. Impaction, it's originated from the Latin words impactus, which means pushed against. Archer in 1975 defines impacted tooth as one which is completely or partially erupted and it's positioned against another tooth or bone or soft tissue so that its further eruption is blocked or complicated. The definition of impaction: the impacted tooth is one that fails to erupt and will not attain its anatomical position beyond the chronological eruption date, even after its incidence. Maxillary canine impaction occurs in approximately 2% of the population, twice as common in females as in incidence of canine impaction in the maxilla is more than that, twice that in the mandible. Of all patients who have impacted maxillary canine, 8% have bilateral impaction. Sequelae of impacted canine. The labial or lingual malpositioning of the impacted tooth, migration of the neighboring teeth and loss of arch length, then internal resorption or external root resorption of the impacted or neighboring teeth or tooth. Also dentagerous cyst formation, infection particularly with partially erupted teeth, and also referred pen. Clinical evaluation. There are different evaluations should be taken, such as study models analysis, morphology of the adjacent teeth, contours of the adjacent alveolar bone, and mobility of the adjacent tooth or teeth. Study models. The amount of space available in dental arch of impacted canine is assessed in dental models. Morphology of the adjacent teeth gives up the glue of position of the impacted tooth. Also, contours of the adjacent alveolar bone, canine bulge present buccally or palatally can give us an idea about the positioning of the canine. Also, mobility of the adjacent teeth and whether there is root resorption in the adjacent tooth or teeth. Here we see that there is a bulging in the ridge, and there is malpositioning and labially tipped lateral incisor. That means the canine crown hitting the root of the lateral incisor. Here also the same thing. And here is the bulging, and the canine crown is going to erupt. So the angulation and positioning of the canine is reflected on the adjacent teeth. So we see if there is malalignment of the adjacent teeth, such as lateral incisor. Radiographical examination. There are many radiographical examinations which is considered as a paraclinical examination, indicated an individual with unerupted or non-palpable canines after the age of 11 years of old. 11 years old. Intraoral radiographs such as intraoral periapical and occlusal, extraoral radiographs, OPG and lateral cephalograms, and the recent radiography, which is CT or CBCT, cone beam CT scanner, which substitute the previous old techniques. CBCT. Cone beam CT scanner identify and locate the position of impacted canine accurately. Dentists can assess any damage to the adjacent tooth roots and amount of bone surrounding each tooth. Here we see the canine crown cause root resorption of the central incisor and also the lateral incisor. Here we see that there is acoustic changes and radiolucency around the radio-opaque line surrounding a radiolucent opacity. So there is a radiolucency surrounded by a radio-opaque line, which reflects cystic changes or any adenomatous cystic lesion or tissues around the impacted canines, and as we can see in the also here there is a radiolucency around the canine's crown and tooth. Here there is root resorption of the permanent lateral and central incisors due to the pathological changes associated with the impacted tooth. Here also we can see in the CBCT bilateral canine impaction causing root resorption of the anterior teeth. So the most important thing, we should take a CBCT before any clinical application of fixed comprehensive orthodontic appliance. So we should do the CBCT, which is considered as paraclinical examination, in order to put a scientific background treatment planning. We should consider the CBCT in different X and Y and Z during the CBCT in relation to the long axis of the teeth and adjacent teeth, also to the mid-sagittal. Positioning of the canine. The canine angulation to the midline is one of the methods to determine the accurate positioning or to put an idea about the prognosis of the treatment of the canine. Grade 1 from 0 to 15 degree to the midline. Here is the angulation of the long axis of the canine to the midline. Grade 2 is 16 to 30 degree, and grade 3 is the 31 degree. When the degree of angulation increases, the prognosis will be decreases. Also, another method for positioning of the canine by vertical height of the impacted canine from the X-ray. It is divided into 4 quarters or sectors. The quarter number 1 within the clinical crown, quarter 2 from the cervix of the adjacent teeth to the mid of the roots, quarter 3 from the apical part of the roots till the apices, and the sector or quarter 4 is above the root apices of the adjacent teeth. This is one method of determining the crown position. The position of the canine apex relative to the adjacent teeth is another method. It's divided into 3 sectors. Sector number 1 relocated in the normal area of normal eruption of the canine. Sector 2 is positioned to the first premolars, and sector 3 is positioned on the second premolar. Mediodistal position of the canine tip to the adjacent tooth also divided into 4 sectors in relation to the lateral incisor. Sector number 1, when the canine tip positioned distal to the tangents of the lateral incisor, while the sector number 2, when the canine tip positioned distal to the midline of the lateral incisor, and sector number 3 is positioning of the cusp tip of the canine medial to the midline of the lateral incisor, and the sector number 4 when the cusp tip located here, which is medial to the medial tangents of the lateral incisor. Erickson and Curl in 1988 defined number of sectors to denote the different types of impactions. Sector number 1, when the canine cusp tip located between the interincisor midline and the line positioned with the long axis of the central incisor. This is sector number 1. While sector number 2 is when the canine cusp tip located between the median line of the central incisor and distal tangents to the central incisor. While the sector number 3, when the position of the canine crown is located between the tangents of the line to the central incisor and the midline of the lateral incisor, while the sector number 4 is located between the midline of the lateral incisors and the tangents to the distal aspect of the lateral incisors, while the sector number 5 is located between the tangents of the distal aspect of the lateral incisors and the medial tangents or medial on the medial aspect of the first premolars. Modified Erickson and Curl's definition of sectors used in the study, where the sector 1 located distal to the tangents of the distal crown and root of the lateral incisors, this is sector number 1, while the sector number 2 is located from the tangents of the distal surface of the lateral incisors to the midline bisector of the lateral incisors, while the sector number 3 located between the midline of the bisector of the lateral incisors and the tangents of the medial aspect of the lateral incisors, while the sector number 4 all area medial to it, or area which is medial to the tangents of the medial aspect of the lateral incisors, which is medial area to the sector number 3. Treatment alternatives. Usually no treatment if the patient doesn't desire it, since the long-term prognosis of deciduous canine is poor as its roots may eventually resolve. It should be periodically evaluated if we leave the canine without treatment. Auto-transplantation of the canine, extraction of the impacted canine, moving premolars in its position, extraction of the canine and posterior segmental osteotomy to move the buccal segment medially to the close to the residual space. Prosthetic replacement of the canine not amendable for juvenile cases. And most desirable approach is surgical exposure of the canine followed by orthodontics. The law in orthodontic, which is never ever extract the canine, is not always true. So we can extract the canine cases of when patient declined the active treatment and or is happy with the appearance. There is evidence of early resorption of the adjacent teeth, which is especially important thing if there is root resorption of the adjacent tooth or teeth. And patient is too old for interception of the orthodontic treatment, and he has no time to waste for longer period of treatment. And there is good contact of lateral incisor and first premolar. The patient is willing to undergo orthodontic treatment to substitute first premolar for the canine. If the impacted canine is ankylosis and cannot be transplanted, or if the root of the canine is severely dilacerated, or if the impaction is severe and degree of malocclusion is too great for surgical repositioning and transplantation, or if the canine is not applicable to conduct the treatment. General steps in mechanotherapy treatment of surgical exposure of the canine. Usually alignment or leveling of the erupted teeth, creating enough space for the impacted canine and maintaining it, conversion of the arch into a rigid anchorage unit, and surgical exposure of the canine and attachment bonding, application of low force, which is nearly a 60-gram traction from the rigid anchorage. Management of affected canine, usually interceptive treatment, treatment of labial impaction, treatment of platal impaction, methods of applying the traction and retention. Interceptive treatment. When the clinician detects early signs of ectopic eruption of the canine, an attempt should be made to prevent their impaction and its potential sequelae. Selective extraction of deciduous canines as early as 8 to 9 years of age. Normalize the eruption of ectopically erupting permanent labial impaction of the upper canine. Due to ectopic migration of the canine crown over the root of the lateral incisor or insufficient space in the arch caused by midline shift of the dental organ. Arch length tooth material discrepancy is the most common cause, and extraction of deciduous canine as early as of 8 to 9 years will enhance eruption and self-correction of labial impaction. So we will guide it, which means guidance for eruption. Initial orthodontic treatment was aimed at creating space in the maxillary arch with fixed appliance therapy and surgical exposure and orthodontic traction, as we can see here. Surgical exposure indicated when the tooth doesn't erupt spontaneously after creating space in the arch. Attempted 6 months after the root formation. Flap design should preserve the band of attachment gingivae and should guide tooth to erupt through its natural path. Open technique, which means a surgical approach. Canine crown coronal to the mucogingival junction, so excisional approach can be conducted. And when the canine crown apical to the mucogingival junction, apical position the flap can be conducted. Here is space creation by pushing coil to create space and extrude the canine vertically by placing double arch wire, one rigid and one flexible. Here a case of open flap. We put the attachment and then threading the wires and place it as a hook-like to protract the canine to its normal position. Here, another case of apical positioning flap. They do exposure of the canine and passing it through the wire attachments behind the periosteum and placing a bondable mesh on the canine and passing through the threaded pins to be attached to the main arch wire to conduct a force of protraction. Attachment for the canine. Lasso wire, which is Shapira and Kaftinic. Here is the lasso. The lasso is similar to a lasso. Pull control over direction of extrusion. The risk of external root resorption near semitominal junction, near these areas, and risk of velar crest bone loss and loss of attachment epithelium. We will get apical migration of the junction epithelia. which means that we will get an increase in clinical crown complication of the periodontium. Another method is orthodontic bands, which require extensive bone removal. Another is threaded pins, Becker and Zilbern. Chances of non-vitality of the tooth, needs restoration of the tooth at the end of treatment, which is an old technique. We can also apply standard orthodontic brackets, easy to perform, a more reliable method and less time consuming. Another method is applying an elastic ties. Advantages: application of light force, good range of action, easier to tie. Disadvantages of these elastic ties: tends to loosen, it will undergo fourth decay with time. Attachment for the canine magnets during development stage, greatest disadvantage is corrosion. Method is clumsy and inconvenient. Another method, here is them with magnet. Cast canine cap, Lewis dual, require extensive crown preparation. Treatment of an impacted canine with magnets. Here is the reference for attachment of the canines. Advantages of an eyelet welded to can band material with a mesh backing is soft and easy to contour, and it is adaptation to the bonding surface more accurate, which makes the superior retentive properties. Because of small size, they can be placed more awkwardly placed teeth. It is less irritating to the surrounding tissue. The gold chain is by applying a gold chain on the canine, and their weights will cause extrusion of the impacted canine. Methods: applying tractions. Ligature wire, as we said, threaded wires, rubber bands, elastomeric chains, and elastic threads. Force generating devices. Active palatal arch. We can apply active palatal arch with helices to apply an elastics from these arches to the accused canine. It consists of fine 0.020 inch removable palatal arch wire carrying an omega or helix on each side. End of the wire is doubled for frictionless fit in lingual sheath. It is activated by elevating Darrow's activated palatal arch wire and hooking the pigtail ligature around it. Ballista springs, or sometimes called mousetrap loops. The ballista, it is similar to the ballista which is used in medieval periods as in the war during the medieval periods. It is made of rectangular wires. It proceeds forwards until it's opposite to canine space and bend vertically downwards and to terminate its into a small loop. With a small loop. With slightly finger pressure, the spring is tied into pigtail ligature here. It provides an extrusive force for the canine to erupt in. Here's the ballista. One wire is bent to similar to small loops and squeeze it to enter in the main slot of the tube, and the other is placed in the accessory loop. Then we do bending to pass it through the premolars, then vertical right angle bends with the small helices and non-traumatic ends. Sometimes in this ballista we can do here a helices between the medial of the 6 and distal to the 5, or sometimes between the 5 and 4, to increase the flexibility of the wire. Here is the ballista passing through the premolars. It is made usually with 17 by 25 mm TMA. Simple in design, no patient compliance, light continuous eruptive and distalizing forces, and it is very rapid in action. Another method for force generated devices, by applying 2 arch wires. One is the main arch wire and the second arch wire with a vertical loops. Light axillary labial arch by Kornhauser 1996. This loop has a small helix wire is tied with the basal arch wire in piggy bag fashion. So this method is called piggy bag when we use a main arch wire, rigid arch wire, and the second stainless steel light wire with a small helix. So this called is a piggy bag fashion. If basal arch wire is not used, it will lead to extrusion of the adjacent teeth, causing the cause alteration of the occlusal plane, and it will complicate our case. Here is the application of piggy bag fashion, main rigid arch wire with a small light stainless steel wire with a small helix. So we apply by a ligature wire the bonding attachments with the ligature wire to the inverted stainless steel piggy bag fashion to extrude it in its place. Piggy bag fashion here also when we use 2 double wires, 1 rigid wire and 1 light wire. It is called piggy bag fashion. TMA box slope, TMA 7025 mm wire used, produce sagittal and horizontal correction while continuing vertical eruption. Cantilever spring, initial extrusion mechanics with a cantilever, use of box slope to continue canine extrusion and to make first and second order correction, incorporating of the canine into a continuous arch wire. Usually we use 1725 TMA wires, titanium molybdenum alloy wire. Austrian helical arch wire made in special plus 0.16 of an inch arch wire. Force should not exceed 200 grams because it is an extrusion force which is dangerous because it is rapid tooth movement. We can get it. Activation by twisting the steel ligature wire every 2 weeks to do extrusion. Monkey Hawk Baumann 2002. It is a simple auxiliary with an open loop on each end, for attachment of the intraoral elastics or elastometric chain for the connecting to a bondable loop. A combination of monkey hooks and a bondable loop buttons can be applied in a variety of different directions. Here is the monkey hook and with chains, maybe single hook, monkey hook, and maybe double hook, so we can apply different angulations. Here is the monkey loops, 3 monkey loops, hooks in different direction. Here is the monkey hooks. We can apply in different direction to move the canine to its side. Kilroy spring is similar to cheeks and with elongated nose. Kilroy spring is a constant force module that is slide onto the rectangular arch wire over the side of the impacted tooth in a passive state. Vertical loop extends perpendicular from the occlusal plane, and to activate the spring, a stainless steel ligature is guided through the helix at the apex of the vertical loop, as the loop is directed towards the impact. Here is the Kilroy springs, and it is directed palatally to extrude the canine by a ligature wire to its Kilroy spring 2 was designed to produce more vertical than lateral eruptive forces for eruption of buccally impacted canine. It has multiple helices, increases its flexibility, but also increases the likelihood of impingement of the adjacent soft tissue, sometimes cause soft tissue trauma. This is another method of Kilroy. Here is also the Kilroy spring. Also, we can apply a mini implant in the palatal direction with a length of 10 or 11 to move the canine in different directions. Determining of the prognosis. Factors influencing the treatment decision of an impacted canine. First is the age of the patient, availability of the space, favorable position of the canine, and presence of adequate width and of the attachment gingiva. So, usually, when the canine is near the crest of the ridge, we will get a good prognosis. Here, if we divided the height of the adjacent teeth to quarters or sectors, when the canine crown positioned at the mid of the root or near the crest of the ridge, we will get a good prognosis. So when it is more apically, we get a fair prognosis. When it is located near the apical quarter of the adjacent tooth, we'll get poor prognosis. Here also, and this is in horizontal direction, while in the vertical directions, if we apply sectors on the central and lateral, also when we are moving towards the medial direction and away from its normal site, we'll get a poor prognosis. Here, fair prognosis, and when it is distal to the midline sector of the lateral incisors, we'll get a good prognosis. Success rate and duration of the treatment. If the canine was impacted less than 40 millimeter from the occlusal plane, treatment duration average 23.8 months. If the canine was impacted more than 14 millimeter from the occlusal plane, the treatment duration average 31.1 months. So this is a research by Stewart in 2001. So we should consider in the treatment plan, we should consider the prognosis of the treatment. When it is not, you are not a hero to put the canine to its place with more damaging to the adjacent teeth or the bone or soft tissue and surrounding structures. So the prognosis should be considered. You are a hero if you do minimum damage to the surrounding tissues when you put the canine to its normal place and within less complicated treatment. So Jonathan Butler, he puts guidelines for assessment of impacted maxillary canines. The category overlap of the incisors, vertical height, angulation, and position of the apex. All these four categories should be considered to put a treatment plan for the success of the treatment of the canine. So good prognosis when the overlap with the lateral incisors, no horizontal overlap with the adjacent incisor. Vertical height when cementomal junction halfway to the halfway up root. This is good prognosis. When the angulation of the canine 0 to 15 degrees to the long axis, so we'll get a good prognosis. And position of the apex. The green area is the canine has a good prognosis, while the yellow area the canine has fair prognosis. When the red area, when the apex in the red area, the canine will get a poor prognosis. While the average prognosis, when the canine overlap up to half root width, while the fair prognosis when complete overlap with the adjacent tooth. The vertical height also half or less than full root length. So this is an average or fair prognosis in the yellow area, while a poor prognosis in the red area. And when the angulation is 16 to 30 degree, you'll get a fair or average prognosis. And when more than 30 degree, you get a poor prognosis. And position of the apex, as we said, when it is located in the red area, so we get a poor prognosis. This is very important classification for the prognosis of the impacted canine. So as we said, if you get a good prognosis when the canine followed these criteria. Retention consideration. Relapse of rotations and spacing may occur after completion of the orthodontic treatment of the impacted canine. Supracrestal fibrotomy and fixed retainers, removal of the half-moon shaped wedge of tissue to prevent lingual drift of palatal impacted canine. Conclusion. Various surgical and orthodontics techniques may be used to recover impacted maxillary canine. Proper management of these teeth requires a proper surgical technique to apply forces in favorable direction and to have complete control of the efficient correction, thereby avoiding damage to the adjacent teeth. The management of impacted canine is a complex procedure requiring multidisciplinary approach. The clinician should communicate with each other to provide the patient with an optimal treatment plan based on scientific rationale. Other references for my lecture. Thank you for your attention and goodbye.